Thanks. Yeah, this next section we're going to be talking about some totally endovascular sort of strategies. So Ali asked me to talk about left subclavian revascularization done endovascularly. Disclosure slide again. So when it comes to options for the left subclavian artery, you can just cover it completely, and that's still sort of our option in patients who are undergoing emergency surgery, and that can be done relatively safe, and I mean relative to the risk of the emergency, unless of course they have a IMA that's dependent upon flow or something, then we may do it at the same time during an emergency. Otherwise, the current standard, and still is commonly used in our institution, is to bypass or transpose that left subclavian artery up front before performing an elective thoracic endovascular aortic repair, or we see that there are these endovascular revascularization solutions, and that's going to be the focus of what I'm talking about today. One of the most common techniques I've been using lately is an in situ laser fenestration, which is an off-label technique, but a relatively valuable one, certainly mostly because it's readily available to us. Parallel grafting is another readily available off-label technique where you can branch something alongside a thoracic stent graft that has issues with regards to endoleak and durability. And then hopefully we'll see, as these trials progress, we'll have more devices available to us that have branches that are incorporated in a commercially available device. They are investigational right now. There's the Medtronic Mona Lisa device that has been in trial for a while, and the Gore TBE device as well. We saw a nice presentation from Dr. Desai demonstrating its use in a zone 0 position. This patient that I'm showing is a 70-year-old who had a type A dissection repair with a kind of conventional supracoronary graft and hemiarch repair in 2007. It was complicated by a sternal wound infection that required a pretty complex reconstruction and sternal debridement and muscle flap. He's got several other comorbidities. And so a redo arch replacement in our institution typically, we'll describe a mortality and stroke risk of less than 5%. I thought in this guy that might be a little bit higher. But on CT scan, he was found to have some growth of this false lumen at the distal arch. He did have no evidence of dissection at the distal suture line of his supracoronary repair, and you can see his dissection extended all the way through his aorta, beyond the bifurcation of the aorta. So we planned for a thoracic endovascular repair. Again, that most worrisome thing was that focal area that was dilated in the distal arch. Plan in pretty much all of our chronic dissection patients is to cover them from that proximal landing zone, which usually requires covering the left subclavian artery, to the celiac trunk. When we perform these operations, I typically will size them at that proximal landing zone between the left common carotid and left subclavian artery with a minimal amount of oversizing. It's critical to use three-dimensional CT and make sure those studies are acquired well when you do that. We always use IVUS for these operations, even when it seems like the wires are going in the right place sort of readily. You have the potential to get burned. And in these cases, you don't even want that 1 or 2% risk of having your wire in the wrong place. We use ultrasound guidance for brachial access, and we do these now more often than not percutaneously with a per-close sort of technique, and ultrasound guidance is helpful for placing those needles. And as I'll point out at the end, you got to be careful of the left subclavian artery. So here we've got access from the groin, we've got access from the left brachial artery. You can see the pullback of the intravascular ultrasound shows that our wire, there's the arch branch vessels you can see on the IVUS on the right side of the screen as the probe's coming back. That also helps to confirm our location. There's the left subclavian artery, and now we're in this dissected aorta, and this wire is in the true lumen throughout its course. You can see that false lumen's partially thrombosed, which makes it a little more dangerous. And I think that's just because it demonstrates that there's unequal pressurization of that false lumen sac, which is essentially like a giant pseudoaneurysm in these people with chronic dissections. And we use the intravascular ultrasound not only to confirm that the wire's in the true lumen through its course, but also to look at these visceral vessels and their locations. It's another nice sort of confirmatory technique. You can see the renal arteries just came off of different lumens there. And so we're happy that the IVUS looks good. Now here's the TEVAR portion. In this patient, because the stent graft was smaller distally than proximally, we put the distal stent graft in first. This is deployed, and it's a typical TEVAR procedure, deployed over a Lunderquist wire, and the distal end is right down around T12, just above the celiac trunk. We use that left subclavian access to perform our angiography for the, again, for the standard TEVAR portion of the procedure. This device is deployed with the proximal end of the fabric right at the distal edge of the left common carotid artery. And again, this deployment is nothing unique from a standard TEVAR, as has been done for quite some time. The bare stent is deployed after deploying the rest of the stent graft. We will shoot some intermittent angiograms to confirm that we're happy with where we're positioned. For these chronic dissection procedures, we think it's important in order, oh, we broke that balloon. That was a stiff dissection flap down there. But we think it's important to try and promote this reverse remodeling process early. And so we do balloon fracture fenestration of the chronic dissection flap through much of the course of the treated area. And so we balloon this whole thing. This one's not such a dramatic video because the guy's aorta is not that big and beyond that more proximal segment. But you can see the balloon is helping to expand that stent graft a little more and actually fracture the dissection flap to get the stent graft opposed to adventitia, which is really where it needs to be if we're going to maintain the principles of aortic repair. Then we do the laser fenestration. And so there's a 5 French sheath coming from the left arm. There's the 2 marks there are the end of the sheath and then the laser within it. And here we go to that RAO position to make sure that things are lined up in an orthogonal plane, and there the laser just popped right into the graft. After that, we deliver a wire and then a balloon. This is a 6 millimeter balloon, and it's important to see when we blow this balloon up that there's a waist in the balloon. That's just extra confirmation that we've actually created a hole in the thoracic stent graft and not ended up somewhere alongside it. Once we've done that, we pass the wire through, we snare that wire, we get through and through wire access. You can see there we're snaring the wire in the descending aorta inside of the stent graft. Because the branch graft that we deliver from the femoral access usually needs to go through a rather large delivery sheath. We don't want to put anything too large in the brachial artery or the axillary artery, although we can get up to probably 8 French if we cut down on the brachial artery. I still prefer to keep it to 5 or 6 French if we can. And then we deliver one of these covered balloon expandable stents. This is an atrium stent that's positioned with about 5 millimeters of the device inside the aorta component. We delivered that from that through and through wire through a sheath in the groin. We expand that device. And we have good mating of the 2 systems, one to the other. And here's a completion CT scan. There's the stent in the left subclavian artery with good apposition. And we've created a branch graft for this patient. The false lumen is thrombosed and healed all the way down through the whole thoracic aorta. We balloon those walls together. But of course, they're left with residual dissection distally because the distal reentry tears. But we're not worried about that too much because there's no aneurysm distally. Malalignment is sort of the main problem that we run into with this. The left subclavian artery doesn't always hit the aortic arch in a square plane. Many times the left subclavian artery is a very tortuous vessel, as you could see on that angiogram on the right-hand side, demonstrated quite a tortuous one. Getting the sheath aligned so that the laser actually hits the cloth directly can be difficult. Some of the techniques have used to address that are putting a small an over-the-wire Fogarty balloon to try and line it up so that it sits in a straight plane against it, and initially poking through with the back end of a stiff wire. It'd be nice if we had devices that were specifically designed for this, but we've had technical success in at least 90% of the cases. An alternative, if you can't get it, maybe a backup plan will be to do parallel stenting. You can see here's a patient where the covered stent is used to maintain flow in that left subclavian artery, but still allowed us to get a few more millimeters of proximal seal in this patient where we wanted to cover a chronic dissection tear. The key points for this laser fenestration are to understanding the anatomy, understanding the limitations of the technique. Visualization is critical. So you not only need to look at that aorta in your typical LAO position where you want to line up the device in an orthogonal plane, but it's important to use that RAO view to understand where the subclavian artery is entering the arch, because it's typically not coming off the crown of the arch, but often a little more posterior. And understanding the angles from a craniocaudal position can also be helpful. That through and through wire access, I think, is important. Once you do get the laser through the device, don't lose the wire, snare it, maintain it, and then you can use your large sheath from the groin to deliver anything you want into that left subclavian artery. I pointed out the importance of that sort of confirmation that you're in the device. You can also pass an IVUS probe over that wire to confirm that you're actually in the proper place. Angiographic guidance from above is also helpful, so we put a longer sheath in the left brachial artery, and we'll shoot angiograms to help guide us along the way. Now, the investigational devices include the Medtronic Mona Lisa device, which is a modular system with a branch built into the main aortic component that's like a volcano coming from the top, and then a separate branch device for the left subclavian artery, which is made for this device itself. That left subclavian branch is a nitinol helical stent on polyester fabric. You can see on the right side is the distal flare. The distal flare is the part that mates to the cone that comes from the main aorta component. They're all 40 millimeters in length and come in a few different diameters. The delivery system for that branch is 15 French, which can be delivered through the same femoral access as the main body. So the way we do this procedure is we get both femoral and brachial access in a hybrid operating room. Here's a demonstration of one of these procedures. So we've got access from the left brachial and the groin. We put our distal stent already in this patient, and now we've snared the wire that we delivered from above. There was a preloaded wire in the device. It's a double wire device. And so now that we've got two wires, one in the proximal aorta, one in the brachial, we take a look through this REO view to make sure we don't have wire wrap. We don't want the wire in the left subclavian branch to be wrapped around the device. Once we confirm that we're happy with that, we then deploy the stent graft system. And as we're uncovering the main body stent graft, you can see it sort of creeps forward into the position. We have an angiography catheter coming from the other groin to help confirm the position of the left common carotid artery. And it's a slow, careful deployment. We can make some micro adjustments to the positioning of this, but that through and through wire that we have in the left subclavian branch, we hold tension on. That helps to align that cuff. And you can see those two big rings where the cuff is. The larger one is the base of that volcano. The smaller one is the tip of that. And then once the device is fully deployed, oh, that's an anesthesia thing. Patient's coughing there. Yeah. The device is fully deployed in the aortic position. but we've maintained that through and through wire that goes through the branch. We then just make an exchange for a sheath in the groin, and then deliver this 15 French system to the left subclavian artery through that 20 French sheath in the groin, and then deliver the branch device. These tend to creep forward a little bit, and so we keep some back tension on the device as we're slowly and carefully deploying it, and we want it so that the flare on the back end of the left subclavian branch is sitting in that cone. We don't always balloon this, but in this patient I chose to balloon that little overlap zone where those two systems are mated together. We can balloon both if we need to. We balloon them simultaneously. There's a completion angiogram, which shows a good repair. And here's a completion CT scan, which shows a good repair in this patient. The Gore device, again, we saw it in zone 0. They've done 62, I believe, to date. Many of those have been compassionate use, like that zone 0 case we saw, and many of them have been for a left subclavian indication. This system also is a 2-component system with a main body device and then a branch device. The branch is delivered into an internal cuff. And then they also have some additional ascending extension cuff pieces which allow them to extend the repair a little bit if you need to fine-tune your proximal seal zone. That interportal and branch are mated together, and there's little anchors on the side of that branch. So they also have a separate component. This is a completely new device for left subclavian artery branch, just as it was for the Medtronic device. The procedure is performed by first inserting the 2 guide wires and then delivering the device over those 2 wires in position in the arch. Although it doesn't show it on this cartoon, that left subclavian branch wire is often snared. The main body is deployed, and then another introducer sheath is delivered from below into that internal branch. And then the second piece is advanced and then deployed to complete the branch graft repair. So something when performing these branch device operations, regardless of what sort of technique, is you need to understand the disease, and it's important to understand the left subclavian artery and be careful of these left subclavian artery dissections. They can pose problems in the follow-up period. For example, in this patient, you see the dissection goes beyond the takeoff of the left vertebral artery, which means there's an entry tear distal to that in this patient, which can continue to perfuse the false lumen. Not only does this patient have that, but there's also an entry tear and a communication with the false lumen at the base of this vessel. Hopefully that gets covered with the branch, but not necessarily so. And this issue of having retrograde flow into the false lumen from a re-entry tear in the left subclavian artery is something that you need to think about and address. It can be addressed with simple embolization or extending the branch, but it's something that needs to be understood. And so some of the commonalities with these various techniques, these branch techniques for treating the left subclavian artery that I think are important tips and tricks are using double wire access. I think that a through and through wire facilitates that better. To avoid wire wrap, it's important that you confirm your visualization using an RAO view in addition to an LAO view. There's a snare that's made by Cook that's got an over-the-wire snare that might be helpful for the snaring portion of that to help eliminate some of that wrap issue. And with any of these patients, remember, we're treating people not just with descending aortic disease, but arch disease. That's why we're bringing a device into the arch. And those people can be at higher risk for stroke. So you want to minimize the amount of manipulation in the arch of these patients, and maybe even not treat them if they have severe atheromatous disease in their arch, because the risk of stroke can be high. And understand the details of these devices and their limitations.